Good morning, everyone, and welcome to today's CCR. I, Dr. Rajiv, on the behalf of Department of Endocrinology, welcomes you all. And today we are going to present a case which gave us lots of diagnostic and management challenges. And with the support of our hospital and the multidisciplinary team, we were able to manage this case. And I would encourage all of you to interact and engage in the case, and we all will try to learn some new point from this case onward. So today we have Dr. Puneet from Department of Endocrinology, second year DM resident, who is going to present this case and take the discussion forward. Dr. Puneet, please.
So good morning all the respected teachers and my dear colleagues. Today I am going to present CCR of a 15-year-old adolescent with weight gain. So a 15-year-old male child presented to endocrinology OPD with the chief complaints of weight gain since 3 to 4 years. He was growing well till 12 years of age. He gained 14 to 15 kgs of the weight in last 3 to 4 years, which was gradual, progressive and generalized in nature. It was not associated with excessive hunger or significant increase in diet. Patient was reasonably physically fit. He used to play outdoor games with significant physical activity. As the food intake was not able to explain the amount of weight the child had gained, so we needed to deep digger, and on further questioning, patient revealed complaints of bilateral lower limb weakness for last 5 to 6 months, which was progressive in nature, and he used to find difficulty in rising from squatting and sitting position, mild difficulty in climbing stairs. There was no involvement of the upper limbs. There was also appearance of dark colored stretch marks on both the flanks over the past 3 to 4 months, which were progressively increasing in dimensions. There was no history of subnormal intelligence, learning difficulties, deafness, visual problems. There was no history of cold intolerance, dry skin, hair thinning or constipation. There was no history of headache, visual complaints, chronic medication intake or any substance abuse. There was no significant past history. There was no history of similar illness in other family members except in his mother. There was history of excision of hyperpigmented skin lesions 20 years back, the exact details of which are not available. There was a history of hysterectomy 6 years back in view of some uterine growth, the exact details of which are not available. On nutritional history, he used to take mixed diet and total calorie intake on 24 hours recall was approximately 2200 calories per day, which was appropriate for his age. He used to play outdoor sports for almost 2 hours daily. His psychosocial history was normal and his sleep and bowel and bladder habits were normal. So to summarize the case till now, 15 years old male came with progressive weight gain of 14 to 15 kgs over past 3 to 4 years with age appropriate physical activity and calorie intake. There was difficulty in rising from squatting or sitting position from past 5 to 6 months, and there were progressive stretch marks on both the flanks over the past 3 to 4 months. So here I would like to ask the audience, what should be the possibilities when a patient is coming to us who is a child and coming with obesity? So anyone could just tell or answer. So the causes of obesity in a child can be broadly classified into 4 categories. First one is the lifestyle related obesity, which is also called as the constitutional cause, which is the most common cause in this age group. The other causes include hormonal causes like Cushing syndrome, hypothyroidism, pseudo-hypoparathyroidism, which is the second most common cause. Then there are monogenic causes of obesity and syndromic causes of obesity. In our case, based on history, lifestyle related obesity, syndromic obesity and monogenic obesity appeared less likely. So in our case, based on history, lifestyle related obesity, syndromic obesity and monogenic causes of obesity appeared less likely. So we kept the endocrinological causes of obesity higher on the list. On general examination, all his vitals were normal. His height was 156 centimeter, which was coming on the 10th centile when we plotted the growth chart. His weight was 65 kgs, which was coming on the 75th centile. His mean parental height was 175 centimeter, which was coming on the 50th centile. His BMI was 27.7 kilogram per meter square, which was touching the 95th centile on the growth chart. Hence, we labeled him as obese. So these are the pictures of the child that came to us. So now again I would like to audience to just tell what are they actually seeing in the picture. So as we can see that the child has a round facies, the obesity is generalized. Then there is presence of gynecomastia. Then there is presence of acanthosis nigricans over the axilla, over the neck. There is presence of violaceous stria over the axilla, abdomen and thighs. These stria were violaceous, livid, non-tapering and had a depth and width of approximately 1 centimeter. There was presence of supraclavicular fat and hyperpigmented patches over the mucosa. His sexual maturity rating was Tanner stage 3. On per abdominal examination, he had violaceous stria over the flanks. Rest of the abdominal examination, cardiovascular examination and respiratory examination was within normal limits. On examining the motor system in neurological examination, we found that power at bilateral hips was 4/5. Rest of the neurological examination was normal. So to summarize the case till now, 15 years old male child came with progressive and generalized weight gain of 14 to 15 kgs over the past 3 to 4 years with age appropriate physical activity and without any excessive hunger. Bilateral lower limb proximal weakness for the past 5 to 6 months, and on examination there was presence of round facies, buffalo hump and supraclavicular fat, stria over the abdomen, acanthosis nigricans, gynecomastia, oral mucosal hyperpigmented patches, and power at both the hips was 4/5. His hemogram, renal function test and liver function tests including serum electrolytes were normal. His metabolic profile including HbA1c.
You have to give a clinical diagnosis at this stage. What is the clinical diagnosis before you investigate him?
Sir, we kept the endocrinological causes as our topmost priority, and we kept hypothyroidism and Cushing syndrome as our likely diagnosis.
First you should take Cushing syndrome.
Yes, sir.
Second could be thyroid.
Yes, sir.
So, no, but he's going on to investigation, that's why I interpret. So, Cushing syndrome with normal blood pressure.
So usually when a child is coming to us at this age group in Cushing syndrome, patient usually doesn't have a lot of obesity as we see in adults, like a centripetal obesity, number 1. Number 2, they do not usually present with hypertension. Number 3, when we investigate them, they usually do not come with abnormalities of serum electrolytes. So these 3 points and one more point, they may present with short stature. So these are the 4 points which differentiate patients of Cushing syndrome in pediatric age group versus the patients of adult age group.
And the point which Dr. Swankar also mentioned, between thyroid and adrenal, would adrenal not be higher?
Cushing syndrome should be the first diagnosis in our case because of the presence
Because
of...
you mentioned thyroid as first.
Cushing syndrome should be the first, I beg your pardon. And because of the presence of...
Adrenal fatigue.
Yes, sir.
Correct answer at this.
Yes, sir.
So age appropriate physical activity is like a very vague term. Age appropriate when I was 15 years old, age appropriate when Rajiv was 15 years old, and when you were 15 years old, it varies era to era. So it should be more objective, I think.
Yes, sir. So his metabolic profile, including HbA1c and lipid profile, was normal. His calcium profile and thyroid profile was also normal.
Where is the blood sugar?
Sir,
That would be an extremely important test in this patient, no?
HbA1c, sir, by the HbA1c we ruled out, sir. So based
Blood sugar should be done. Not mentioned.
based on history and examination, we could rule out the lifestyle related obesity and syndromic and monogenic causes of obesity. Based on calcium profile and thyroid function test, we could rule out pseudo hypoparathyroidism and hypothyroidism. Based on the presence of stria and proximal muscle weakness associated with obesity, Cushing syndrome was the most likely diagnosis. So we decided to evaluate the patient along the line of hypercortisolism. So on further investigations, we found that basal cortisol levels were very high. So it is often said that diagnosing a Cushing syndrome is like navigating in a desert. Why? Because it requires a stepwise approach. A small mistake can feel like being lost in the desert. So when we get a high value of basal cortisol, the first step is always to prove that it is actually pathological rise of cortisol. So to prove this excess cortisol which is pathological, a protocol of doing certain confirmatory tests is followed. So we performed midnight cortisol, overnight dexamethasone suppression test and low dose dexamethasone suppression test. All of them were raised. And we proved that it was an endogenous autonomous hypercortisolism, which is nothing but Cushing syndrome. So before proceeding further, I would like to explain in brief about the normal physiology of the HPA axis. So hypothalamus releases corticotropin releasing hormone. It acts on the corticotropes of the anterior pituitary, which produce ACTH. This ACTH acts on the adrenal to produce cortisol. The cortisol has a negative feedback inhibition on the anterior pituitary and the hypothalamus. The second step is to see the excess cortisol formation is driven by ACTH or not. So we performed basal ACTH levels. We found that the values of ACTH were significantly low, that is ACTH was suppressed. So whenever a patient is coming to us with a history of Cushing syndrome and he is clinically and biochemically confirmed Cushing's, we do ACTH levels, and if the levels of ACTH are less than 10 picogram per ml, we call it as suppressed levels. In such a case, the culprit pathology lies in the adrenals. That is, adrenal is producing excessive cortisol and it is causing a negative feedback on the pituitary and causing the suppression of ACTH. So our main focus is on the adrenals here. However, if the ACTH is more than 20 picogram per ml, it is called as ACTH dependent disease and the main source is pituitary here. So pituitary is producing excessive ACTH which is acting on the adrenals and causing excessive production of cortisol. So here our main aim is to find a pituitary adenoma in the MRI cella. ACTH levels of 10 to 20 picogram per ml is called as intermediate. In our patients, since the ACTH levels were suppressed, we labeled the patient as ACTH independent Cushing syndrome and we advised him to undergo CCT whole abdomen by the adrenal protocol. So patient went to outside hospital for the second opinion where he was further evaluated. So the basal cortisol levels and low dose dexamethasone suppression test cortisol at outside hospitals were also significantly raised, which were in concordance with the reports that we got at our hospital. However, the ACTH levels were 16 picogram per ml, which were in intermediate range, which were not in concordance with the values which we got at our institute. So if we see the common etiology of Cushing syndrome in a children who are more than 10 years of age, the most common cause of hypercortisolism is the Cushing's disease, which is the pituitary source in more than 75% of the cases. So in view of intermediate ACTH values and the fact that most common cause of Cushing syndrome in this age is the central Cushing, MRI cella was done, but it was reported as normal. Since the MRI SELA was reported as normal and there was definitely hypercortisolism present in the patient, patient also underwent CT of the abdomen to look for the adrenals, but CT scan of the abdomen did not reveal any adrenal lesion. Since both the radiological investigations were normal, MRI SELA was reviewed by another radiologist, but this time a presence of a suspicious microadenoma of 3 into 3.6 into 3 mm was reported. So before proceeding ahead, I would like to tell two important points regarding the pituitary adenomas. The non-functioning pituitary adenomas are very common in the general population. The prevalence is about 10%. Point number 2 is the Endocrine Society guidelines. They have advised a cutoff of 6 millimeters of a pituitary adenoma to label it as ACTH producing adenoma in a suspected case of central Cushing's. So if the size is less than 6 mm, it is called as equivocal and it mandates further investigation for confirmation. So since the pituitary microadenoma was 3 mm in size and there was no lesion in the adrenal on the CT scan, patient was subjected to inferior petrosal sinus sampling. So inferior petrosal sinus sampling is a gold standard technique which helps to localize the lesion in a patient of Cushing syndrome. It tells whether the lesion is in the pituitary or is it outside the pituitary. So in this technique, microcatheters are inserted from the femoral vein and via the jugular vein we enter into the inferior petrosal sinus which are present near to the pituitary. Blood samples are collected for ACTH from the inferior petrosal sinus at different time intervals and they are compared with the periphery. So if the source of Cushing syndrome is actually pituitary, then the levels of ACTH will be much higher in the inferior petrosal sinus as compared to the periphery. So by this we can take out a central is to peripheral ACTH ratio. So the Endocrine Society has recommended that if the central is to peripheral ACTH ratio is more than 3, then it will be considered as a pituitary source of hypercortisolism. But if the gradient is less than 3, then it is a non-pituitary source of hypercortisolism. So these were the reports of the patient. We can see here that one of the values of central to peripheral ratio at 10th minute was coming out to be 12, that is more than 3. So considering the single value of gradient of central is to peripheral ACTH ratio of more than 3, presence of a suspicious microadenoma, absence of any lesion in the adrenals, pituitary pathology being the most common cause of Cushing syndrome in this age group, patient was labeled as central Cushing syndrome and source was pituitary and he was advised for transsphenoidal surgery.
So this procedure was done at our institution?
No sir, outside. So patient was referred to the Department of Neurosurgery for transsphenoidal surgery at Mahatma Gandhi Hospital, from where the patient was referred to Department of Endocrinology for opinion and review of outside reports was done like MRI SELA and triple phase CT, the details of which will be shared by Dr. Pragya Soni from the Department of Radiodiagnosis.
Good morning, respected seniors and my dear colleagues. I'll be discussing the radiological findings in this case. On review of the MRI scan of brain, which was done outside, we can see that on T2 coronal images, there is a small suspicious hypointensity lesion on the right side of the anterior pituitary. On the dynamic contrast enhanced MRI, we see a small non-enhancing lesion measuring 3 into 3 mm in right side of the pituitary in the second phase, where the rest of the pituitary is enhancing normally. And in the fourth phase, this lesion is heterogeneously enhancing. On the subtraction image also we can see that there is a hypointense area present in the right side of the pituitary. These findings are in favor of a suspicious pituitary microadenoma on right side. On review of the triple phase CT abdomen images, we see that both the adrenals appears bulky, irregular in contour, and they had slight nodularity. As compared to a similar age normal individual, the adrenals are linear and are thin as compared to our patient, as we can see in this image. The left adrenal is also showing a small nodularity here, and both the adrenals appears bulky and irregular. So, our diagnosis was micronodular disease of adrenals, the differentials of which can be primary pigmented nodular adrenal disease, micronodular adrenal disease, or isolated micronodular adrenocortical disease, further which can be confirmed on histopathology. Thank you. I would like to call Dr. Puneet to carry forward the case.
Thank you, Dr. Pragya, for enlightening us with the CT abdomen and MRI findings. So, to summarize the case till now, initially at MGH, ACTH levels were suppressed and we labeled the patient as ACTH independent Cushing syndrome. While at outside hospital, ACTH levels were intermediate, there was a presence of microadenoma and it was ACTH dependent Cushing syndrome. So the patient was referred to Department of Neurosurgery for the pituitary surgery. From there the patient came to us and our aim was to confirm the biochemical diagnosis and review of investigations. So we repeated the biochemical test to look for the source of hypercortisolism. Biochemical test revealed elevated overnight dexamethasone suppression cortisol and basal ACTH levels were suppressed. We also reviewed the radiological investigations at our center where CCT abdomen was showing bilateral bulky adrenals with the presence of micronodules. MRI cella was showing a pituitary microadenoma which could be a non-functioning pituitary adenoma. So the radiological and the biochemical investigations were suggestive of ACTH independent Cushing syndrome. So
What about the petrosinus level, which was high?
Sir, I'll answer the question. It's coming on the next slide.
Then you can't say that it is ACTH independent.
With ACTH, we can say with reasonably confident level why it is adrenal pathology, why the IPSS showed that value and why the other institute have showed intermediate value, that we will discuss. I think that's the whole point. That's the U-turn. The title is the break. We have to break the journey, took the U-turn and then.
Because the other traffic violations कर रहे हो आप.
And this is really, really important. You don't want a neurosurgery done on a patient who doesn't have anything in the pituitary.
So, so now as Dr. Kapoor sir asked the question, so everyone must be thinking about this question only. Why was there a discrepancy in the ACTH values at our institute and outside the hospital? So the answer to this is ACTH uses a particular platform or the assay on which it is being performed. So there may be variations in the hormonal values based on the assays. In fact, there was a paper published in a renowned journal of endocrinology in 2019 which published a case series of patients who were misdiagnosed because of spurious ACTH results due to the use of assay called as Immulite assay, which led to unnecessary investigations like IPSS and even surgeries. So the reason behind the spurious results is the interference of the antibodies with the assay components. So ACTH Immulite assay can result in falsely elevated ACTH levels due to interference of polyclonal antibodies, which can be corrected by using a different assay. So at this point, we confirmed from the outside hospital about the assay they are using for ACTH, and we found that they were using ACTH Immulite Siemens assay, which was the reason for the discrepancy between the ACTH values, while we are using lysine diazorin platform.
So if this is so important on which platform the test is done, it should be mentioned on the report. Every single report of ACTH should mention the technology and the technique used, right? If this is so important and it is documented in literature.
Yes, sir.
So that is the problem with immunoassay, and that is the basic thing we want to highlight, that immunoassays are different from biochemical assays. The platforms really matter. Whoever is performing, ordering the test, and the lab, whoever is doing the test, should be very clear about which assay they are using, which platform they are using. And every assay has their own drawback. It's not that Immunite Siemens is a bad platform. It is a good, very good platform, very commonly used platform, but there are inherent nature of the antibody they use for immunoassay. They have some limitations, which some patients have some heterophile antibodies and all. So yes, so that's why we need to know what we are using it and why we are using it and which platform we are using.
Particularly when the levels are in lower range, this type of thing happens. If the levels are in the higher range, this discrepancy is minimal. But once lower levels are there, one is giving higher values and another is giving correct lower values.
You see, in IVF or reproductive medicine, we are using immunoassays right and left every day, multiple times, and always mention whether it is ELISA platform, ELISA immunoassay or radioimmunoassay, what findings are there. So what they are saying, that platform should be mentioned, is an important thing which should be remembered.
And I think even more important, sir, the person who is reading the report should understand the positives and negatives of the various platforms which are being.
So at this point, we became sure that the patient had ACTH independent Cushing syndrome. So if we look at the causes of ACTH Cushing syndrome, it can be an adenoma, carcinoma, or nodules in the adrenals. The nodules can be micronodules or macronodules. Since there was no mass lesion on the CT scan, and there were no macronodules on the CT scan, so we were left with only the micronodular adrenocortical disease. So to confirm the diagnosis of micronodular adrenocortical disease, we performed a test which is called as Liddell's test. Now what is this Liddell's test? In normal physiology, when we give high doses of steroids from outside, as a response it suppresses the endogenous production of steroids. So in this test, we collect 24 hours urinary cortisol. After collecting the collecting the urine, we give high doses of dexamethasone and measure 24-hour urine cortisol again. In normal conditions, 24 hours urinary cortisol should suppress after giving high doses of dexamethasone. However, when we took this test, we found that the baseline values were approximately 400 micrograms, and post high doses of steroids, the levels were approximately 1400 micrograms. So this is pathognomic of primary pigmented nodular adrenocortical disease, and why this happens is because there is presence of aberrant overexpression of glucocorticoid receptors on the adrenal nodules, which causes a positive feedback stimulation, and there is more than 50% paradoxical rise in the urinary cortisol. So these PPNADs can occur as an isolated entity, or they may occur as an autosomal dominant disorder called as Carney's complex. So it is characterized by cutaneous manifestations like skin pigmentations, presence of myxomas like cutaneous myxomas, cardiac myxomas, and mammary myxomas. There can be presence of testicular tumors or schwannomas. There can be presence of endocrine hyperactivity like acromegaly, or PPNADs causing Cushing syndrome. So to look for the associated features of Carney's complex, we did 2D echocardiogram to rule out the presence of any cardiac tumors, USG testes to look for any testicular tumors, and the genetic testing. So this is the USG of the scrotum, which is showing two round structures which are testes, and both the testes are showing calcifications. So as I told before, testicular tumors are associated with Carney's complex. So the most likely diagnosis was large cell calcifying Sertoli cell tumors, which we suspected without doing a biopsy, as they are found in the Carney's complex. This was the 2D echo of the patient, where there was no sign of any cardiac myxoma. So to establish the diagnosis of Carney's complex, at least two major criteria have to be confirmed either biochemically, histologically, or by imaging. In our patient, there was presence of PPNAD and the Liddle's test was positive, and there was also presence of testicular calcifications. So we could make the diagnosis of Carney's complex in this case. Once we proved that bilateral adrenals were the source of cortisol excess, we decided to go for minimally invasive adrenalectomy, for which we took the help of urology team, the details of which will be shared by Dr. Tushar Aggarwal from the Department of Urology.
Do you think it is unilateral or bilateral adrenal disease? Bilateral.
Thank you, Dr. Puneet. Good morning, respected faculty members and my dear colleagues. Myself, Dr. Tushar Aggarwal. I am from the Department of Urology. I'll be taking the case forward. The patient was referred to us by the Department of Endocrinology with the diagnosis of primary pigmented nodular adrenal disease. The patient was assessed and planned for bilateral adrenalectomy. The patient was counseled about his options: open bilateral adrenalectomy, laparoscopic bilateral adrenalectomy, or robot-assisted minimally invasive bilateral adrenalectomy. After informed consent, the patient was planned for robot-assisted bilateral adrenalectomy. This is the Da Vinci X robotic system available in our hospital, and here, on the behalf of Department of Urology, I would like to express my heartfelt gratitude to our management for providing us with this world-class system. The advantages of robotic in urology are: it offers an enhanced visual field, superior dexterity, better maneuverability, and better access to the areas of concern. For the patient, it is beneficial as it offers more precise surgery, less post-operative pain, fewer surgical complications, and reduced need for post-operative hospital stay. In our case, the patient was planned for surgery under general anesthesia. Transperitoneal approach was used. The patient was placed in an oblique lateral position with the affected side elevated on the kidney rest at an angle of 30 to 45 degrees from the table. These are the images showing patient positioning for right-sided adrenal surgery and for the left-sided adrenal surgery.
Any specific reason for choosing transperitoneal rather than retroperitoneal?
Sir, the other approach available for the surgery is retroperitoneal approach, but transperitoneal approach offers a wider access, the space is wider, sir, better approaching space for the surgery as compared to retroperitoneal.
So reason could be bilateral.
Yes, sir.
Because if you do extraperitoneal, you will have to probably shift the position of the patient.
Sir, the patient's position needed to be shifted in this case as well. For the transperitoneal also, we needed to shift the position from the right lateral to the left lateral position for doing right and the left adrenalectomy.
Why not supine?
Sir, the access to the organ is better in case of lateral position. We have been doing nephrectomies and adrenal surgeries, and this is the position protocol that has been recommended worldwide, and that is the position protocol we follow.
Come back to the same question. If you are anyway changing position, why not extraperitoneal?
Sir, the maneuverability and access to the surgical organ of concern is better.
In this, sir, transperitoneal is always better than the retroperitoneal because of the access, and we are also well versed with the transperitoneal position. The retroperitoneal is a newcomer in this field, and people are doing, but they feel hardships in retroperitoneal surgery because of the less space and poor anatomic position.
So is there a affected side in this patient? I thought it was a bilateral disease. So there's no affected side.
So both the sides. This is the position for the right side.
The painted side is of the right side and the non-painted
other side is for the left side, sir. After insertion of the trocars and docking the robot, the surgery was started. Now I'd like to show a small surgical video of our surgery. The mobilization of the descending colon and the spleen was done. The splenocholic and the splenorenal ligaments were divided, and spleen and the pancreas were dissected to identify the left kidneys and subsequently the left adrenal gland. After identification of the left kidney, the rotas fascia was opened to identify the left adrenal gland. Since the adrenal gland was grossly normal in our case, it was very tricky to separately identify it from the kidneys. But as we have been doing nephrectomies and adrenal surgeries routinely, we identified the left adrenal gland and we dissected it using the robotic endoscissors and robotic bipolar forceps. As you can clearly see, the visual clarity is far better in robotic surgery as compared to both open and laparoscopic surgery. Now for the identification of the left adrenal vein was first identified, and using its upper border, the left adrenal vein was identified. To avoid any doubt about the origin of the left adrenal vein, the left adrenal gland was further dissected and it was seen that no other structure is misdiagnosed as a left adrenal vein. After the adrenal vein was identified for sure, the adrenal vein was dissected from the adrenal gland, and after proper ensuring of the adrenal vein, it was dissected. It was separated from the surrounding structures. Two clips were placed on the adrenal vein on the upper and the lower side, and adrenal vein was divided using robotic endoscissors. After division of the adrenal vein, the adrenal gland with its arterial supply, it was dissected using robotic endoscissors using hormonal current. The dissected adrenal gland, it was placed in an endobag for section subsequently. Similarly, on the right side, liver and the hepatic flexure of the colon, they were mobilized. The hepatic flexure of the colon was mobilized, and the triangular ligament of the liver was divided, and the liver was retracted using a locked forceps. Cauterization of the duodenum was done, and it was mobilized medially. Since on the right side, adrenal vein arises directly from the IVC, so IVC was used as a landmark for identification of the right adrenal vein. After identification of the IVC, adrenal vein on the right side was traced, and after ensuring its origin from the adrenal gland, it was dissected. It was clipped on both upper and the lower side, and it was divided using robotic endoscissors. And then adrenal gland with the arterial supply, it was dissected using robotic endoscissors, and it was placed in an endobag for extraction. Both the adrenal glands were subsequently extracted using a Fenton steel incision given to the patient. The postoperative period of the patient was uneventful. The patient was discharged on postoperative day 5. Hormonal replacement was started immediately after surgery. The surgical specimens had already been sent to histopathological examination to the pathology department, which will be covered subsequently in our presentation. The advantages of robotic adrenalectomy: our patient had a very minimal postoperative pain, and analgesics were only required on an SOS basis. The hospital stay was shorter. Patient was discharged on postoperative day 5. The patient could return to daily activities as better than open and robotic surgery. There was minimal blood loss, and our cosmetic outcome was better. This is a surgery.
Here you should emphasize that if you do open surgery bilaterally,
yes sir,
you have to take a long incision.
Yes sir.
Which will hinder with the diaphragmatic movement.
Okay sir.
All right.
Yes sir.
So post-operative, it becomes very easy.
Okay sir.
If you do laparoscopic or robotic
yes
interventions.
Yes sir. Now, since the robotic surgery is a bit expensive and financial issues may be an area of concern for the patients, but our hospital has very successfully run government assistance programs, and they are of great help in making the patients comfortable to opt for robotic surgery without having to drill a hole in their pockets.
So I can ask a question,
yes, sir,
like
course,
completely non-surgical,
yes,
non-surgical source of the question. You've compared open with robotic. Can you compare laparoscopic
yes,
with robotic
sir,
also?
Sir, laparoscopic surgeries, the degrees of movement and the degrees of freedom that the surgeons experience, it is limited. But in robotic surgery, it has a better dexterity and better maneuverability. Laparoscopic surgery allows us only 4 degrees of movements in the surgery, while the robotic surgery offers us 7 or 8 degrees of freedom. So it is as good as open surgery as far as surgeon is concerned in dealing with the patient.
So all benefits for the surgeon and no major
sir,
difference for the
if the surgeon
patient.
is comfortable, sir, the surgery for the patient will go better, sir. The areas of concern is better, and for the
directly there are benefits to the patient also, because the view and magnification is better, delineation of anatomy is better, and for a vein like adrenal vein, as he said, the right adrenal vein may be very short. It is directly joining the IVC. If it gets injured, it becomes like a hole in the IVC. So there are these finer points which offer an indirect benefit to the patient also.
Sir, it is very fine surgery, and bit by bit the tissue is dissected, and there is minimal blood loss. So blood loss is minimal, and very good sight, very good vision, which gives advantage for the patient as well, sir.
So this is a case series published in European Journal of Surgical Oncology in August 2024. It is the largest case series of robot-assisted adrenalectomy in a pediatric age group patient. The total number of cases of adrenalectomy done were 24, of which 7 cases had bilateral adrenalectomy done for bilateral adrenal disease. There has been no published literature of robot-assisted minimally invasive adrenalectomy from India up till now. And our center is probably the first one to do a robot-assisted bilateral adrenalectomy in a pediatric age group patient. Now, our experience with robotic surgery, the total number of surgeries that have been done up till now using robot assistance have been 151, of which urology department has successfully done 66 cases using robot assistance. we have used robotic surgery for doing simple nephrectomies, radical nephrectomy, partial nephrectomy, pyeloplasties, radical prostatectomies, VVF repair, adrenalectomy, partial cystectomy, radical cystectomy with new bladder formation, ureteric reimplantation, ureteroureterostomy, and seminal vesicle cyst excision. This is an image showing post-operative scar in cases of robotic surgery versus a conventional open surgery, and as you can clearly see, the scar and the cosmesis is far better in robotic as compared to open surgery, and the post-operative patient recovery is also better in robotic approaches.
Just I want to highlight one thing which sir has actually said, especially in settings like Cushing's where there is a muscle weakness, diaphragmatic muscle weakness, intercostal muscle weakness, this large incision subcostal region becomes very important hindrance for us for patient to get out of the ventilator, and if they remain on ventilator they are immunocompromised. Even if we have operated, the recovery of immunity takes long time after Cushing's, and they are very susceptible for infections, and many times it has happened we have done successful surgery but we lost patient after surgery. So this is how we can minimize the post-operative care stay. We can actually save the life.
Also, sir, since in Cushing syndrome wound healing is compromised, so in such an open case it takes a long time to healing, and robotic surgery offers a better wound healing in the post-operative period. Yes, sir. Thank you. Now I'll invite Dr. Puneet for carrying the case forward.
So when you are doing bilateral adrenalectomy, what time do you give the replacement steroid?
Immediately after excision of the second adrenal, we start with hydrocortisone injections. Yes, sir.
The anesthetists are well informed and they give automatically.
Thank you, Dr. Tushar. So, on the follow-up of the patient, post-op day 5 cortisol was 0.18 micrograms, suggesting the remission of the patient. He was continued on the replacements in the form of glucocorticoids and mineralocorticoids. His whole clinical exome sequencing reported a pathogenic variant in the form of deletion of PRCAR1A gene, which was confirmatory for the diagnosis of Carney's complex or PPNADs. But the story doesn't end here. So as I told that Carney's complex is an autosomal dominant disorder, so we had to screen other family members also. So to begin with, we screened her mother first. So these are the pictures of the mother, and if we remember, there was a history of excision of skin lesions, which could be probably semomatous melanotic schwannomas, and there was history of surgery of uterine mass, which could be a uterine myxoma in this patient. We also noticed presence of oral mucosal brownish pigmented patches in the patient. So we advised the mother to undergo biochemical evaluation, where her overnight dexamethasone cortisol was raised and ACTH levels were suppressed, meaning she had ACTH independent Cushing syndrome. So we got the CT scan of the abdomen done, and we found that there were presence of nodules in the kidney and in the adrenal glands. So she was counseled regarding the need for further evaluation like 2D echo for the cardiac tumors. So here is a video showing the presence of a big mass which is nothing but an atrial myxoma. So mother was counseled for surgery of left atrial myxoma in view of high chances of embolic stroke. So, but she wished to get operated at a later date. 7 days later, mother had an episode of right-sided weakness in upper limb and lower limbs. So she came to MGH emergency at 11 p.m. She was admitted under the Department of Endocrinology, and urgent reference was sent to the Department of Neurology, the details of which will be shared by Dr. Pavni from the Department of Neurology.
Dr. Pavni Agrawal from the Department of Neurology. A 36-year-old female presented to us with complaints of sudden onset weakness of the right upper limb and lower limb. While she was working in the kitchen, she dropped the spoon from her right hand. Along with that, she couldn't bear weight on the right leg to an extent that she needed support of one person to walk. The weakness was the weakness reached from baseline to nadir in 10 minutes. This was also associated with change in speech in the form of dysarthria along with deviation of mouth to the left side. She was diagnosed with an atrial myxoma 1 week back. The family history and the personal history was negative for any neurological complications.
On further doing her neurological examination, we found that the patient had right-sided UMN type of facial palsy along with significant weakness of the right upper limb and lower limb. The grip was 50% of that of normal, along with the right plantar response being that of an extensor. Now, what is the etiology of this event? Since the patient had an hyperacute presentation, the vascular event seems to be a most likely diagnosis. Vascular events can be divided into ischemic and hemorrhagic causes. And since our patient had an atrial myxoma and the weakness increased from baseline to nadir in 10 minutes, a cardioembolic cause seems to be most likely. This is the MRI brain which was done in an outside hospital. This shows an hyperintense lesion in the left MCA territory along in the DWI images along with a positive ADC correlate pointing us to a left MCA territory infarct. The patient is a 36-year-old female and hence is a case of a young stroke. There are various causes of a young stroke such as cardiac causes, hematological conditions, non-atherosclerotic angiopathies, genetic causes, infectious and inflammatory causes. But in a background of a cardiac tumor in the form of an atrial myxoma, a cardiac cause seems to be the most likely cause. Hence, with the presence of an atrial myxoma, the weakness, the neurological deficits being maximal at onset, and absence of collateralization on the CT angiography, we ascertain that the mechanism of stroke in our patient is cardioembolic. Now, what are the guidelines on the management of cardiac myxoma-related neurological complications? It is a surgical emergency. A definite surgical resection as soon as the patient is diagnosed with the same is the way to go forwards. Why? Because not surgically managing the case can lead to sudden cardiac death in around 10% of patients, with the recurrence of embolic complications being very high. Also, medical management alone with an anticoagulation therapy is ineffective. So after establishing a diagnosis of an atrial myxoma associated acute ischemic stroke, we gave an urgent referral to the CTVS department to further do a surgical resection, and also we started the patient on anticoagulation therapy. Thank you. I would like to call Dr. Hussainur sir to further enlighten us the case.
तो उसको 37 years तो कुछ नहीं हुआ और आपने एक week पहले इको किया.
We got a call in the 11, like my resident got a call in the 11 p.m. in the night कि सर आपने जो 4 दिन पहले कहा था वो हो गया, and we are bringing her. That's it. That was the word of the.
Do you think?
इससे पहले प्लास्टिक सर्जन ने गायनोकोलॉजिस्ट ने देखा था, उनके दिमाग में नहीं आई ये बात, इनके में आई. So do you think that the manipulation during the echocardiogram might have dislodged the thrombus? Like.
Good morning all. I am Dr. Hussainur Rehman. I am a senior resident in cardiothoracic and vascular surgery department. Regarding this case, this patient was referred to us on 21st of January 2025, and she was referred to us with the chief complaints of slurring of speech and weakness on the left side of the body since one day. So she was evaluated beforehand, and the diagnosis was confirmed that she was having an ischemic brain stroke, and the culprit was a left-sided left atrial mass. So we did an transthoracic echocardiography, and in this echocardiography we had a finding. As we can see here, we had a big mass of around 4.7 centimeter into 2.5 centimeter oscillating mass in the left atrium. This is the oscillating mass, and this mass was attached to the interatrial septum and also abutting to the anterior mitral leaflet. So this was causing a moderate grade of MR, and the ejection fraction of the left ventricle was preserved. It was 60%. So we planned surgical intervention. Now the question is, why should we plan such an urgent surgical intervention in these kinds of patients? The most important cause is the embolization of the fragmented particles, as this has happened in this case. Also, these type of tumors causes obstructive symptoms which lead to congestive heart failures, and there is also a chance of sudden cardiac death if it completely aborts or obstructs any outflow tract. So indication of urgent surgery in this patient was that the tumor mass was large and it was occupying a good segment of the left atrium, and the mass has already fragmented and has caused an ischemic stroke. It is a oscillating mass and it can completely obstruct the mitral valve. So in this case, there is a risk of sudden cardiac death is also associated with it. And here, as we can see that there is an MR already present, so congestive heart failure risk was also there. So what is the risk of planning an urgent surgery in this kind of patient? The major risk that we face is a hemorrhagic transformation of the ischemic stroke. Now, what is an hemorrhagic transformation? This is a very significant complication that we usually see with ischemic stroke during and after the surgery, where there is the transformation of the ischemic stroke into a hemorrhagic form, and this is because as we can see here, because of the active inflammatory process, there is a disruption of the blood-brain barrier. So in the studies, what we have noticed that the autopsy studies suggest that 18 to 42% of all the patients who have undergone a hemorrhagic transformation has landed into a fatal complication. So in this surgery, this is not a very straightforward surgery. We have to take certain precautions specific to this case. The number one precaution that we have to take is that we have to do a none to minimal cardiac handling before we apply the cross clamp on the aorta, so that even if there is a small fragmentation of the tumor particle, it doesn't go and embolize to distal organs. And we keep the patient in a head up position, so that risk of that embolization happening to the brain is minimal. The intraoperative pictures, as we can see here, we have approached this patient through an RA in transseptal approach. So we have opened the RA, go to the LA through the transseptal way. So as we can see here, this is the opened up RA, right atrium, and this is the septum that we have excised, and this granular tissue, as we can see here, which was held with a forceps, is the myxoma, and there is a part of the intraatrial septum that we have also excised. So we were successful to remove the entire tumor with the part of the intraatrial septum which has been attached to the tumor, and this is the specimen that we have retrieved, and we have sent this specimen for the histopathological examination. After that, the patient was shifted to our ICU, where she was extubated after 6 hours. The overall course in the post-op was very smooth, and the patient was discharged on oral medication, anticoagulation and antiplatelet on day 5. The overall event was duration was uneventful. There was no new neurological complication. Now I want to invite my oncopathology colleague to continue with this.
We did have specimens, histopathological specimens of both the mother as well as the son. So the first slide that we are seeing here is that of the son. We received bilateral adrenalectomy, 15-year-old male, a known case of Carney's complex. So on gross examination, we found that the adrenal glands were bulky in appearance. The periadrenal fat along with the capsule was very beady in palpation, and on cut section we were able to see that the adrenal gland is divided into capsule, cortex and medulla. So the capsule and the periadrenal fat was beady looking. The cortex, which was losing its golden yellow color, and it in fact became tan gray in appearance, and medulla was unremarkable. Here we were able to make out these very speckled, surreptitiously hidden pigmented nodules which were present in the cortex. We measured the size of these nodules, which were around 4 mm to 5 mm in size. All were less than 10 mm in size. The same thing is recapitulated here in the low power image of this biopsy. On histopathological examination, there were these compact pigmented nodules which we can be seen. They were very discrete in appearance. They were extending into the cortex, they were going into the periadrenal adipose tissue. Then we were also able to identify that there was this internodular cortical atrophy. That was the reason that we did not find the typical golden yellow color of the adrenal gland, because the internodular cortical atrophy was there, the lipid depletion of the adrenal gland was taking place, and this was a very significant and an essential finding for the diagnosis that we had to come later. On closer imaging, we could see that these pigmented nodules were comprising of these very large polyhedral cells. They were lipid poor in appearance. They had lipofuscin pigment in them. This is a brown colored granular pigment which was present in the cytoplasm of the cells, and these were found in all the compact nodules which were there in the adrenal gland. So, 15-year-old male son, known case of Carney's complex. He was diagnosed as PPNAD. Whatever findings were given biochemically were confirmed on histopathology. He was diagnosed as a case of primary pigmented nodular adrenocortical disease, which was Carney's associated. This was the imaging and gross and microscopy finding of the mother. Mother had a left atrial myxoma. We got this globular myxoid gelatinous appearing mass with multiple villiform projections. There was a pedunculated mass which was probably attached to the septum, which was found intraoperatively also. Microscopically, we could see that there is an abundant dense myxoid basophilic kind of a stroma in which there are cords and trabeculae of the singly lying widely spaced cells which are very spindle to stellate in appearance. There is presence of hemosiderin laden macrophages along with the presence of gamma antibodies, and thus the mother was also diagnosed as a case of left atrial myxoma. So here we did have the findings of Carney's complex, son bilateral micronodular adrenocortical disease which was Carney's associated, and it is said that PPNAD is one of the essential diagnostic features for this entity, and it is found in almost 57% of the patients of Carney's complex. Mother also had a history of left atrial myxoma. I would now like to call upon Kasliwal sir. Thank you.
So just because we are short of time, so he is the index patient. After showing good recovery, lost some kgs of weight, he still have some time to to lose further weight. And that was the I think this is the answer to sir's question. She is walking now, complete neurological recovery, and we need to still see the younger siblings because there is one hyperpigmented patch. So jury is out whether he is also going to be affected or. So it's So further plan is we need to follow the child for that large calcifying Sertoli cell tumor. Most of the time they are benign tumor. Some of them become malignant. So initial part is to radiologically follow them up with USG. And if they show some signs of increase in size and all, then of course we need to go for surgery. Since the age of presentation of myxoma is around third decade, so we need to monitor the child for the development of myxoma in the future life. Mother, she still needs to undergo adelectomy because she is already haven't proven to have Cushing's. There is a 50% chance of recurrence of myxoma in future life, so we need to wait and see how she do it long term. And again, her brother is also having some of these features, so family is still gathering courage to subject them to screening. This is an extensive surveillance protocol which we are going to follow. So I think take home message is use the clinical judgments, put up all the findings. Sometimes it's good to have breaks, sometimes it's good to have U-turn and make a good diagnosis. Maybe it's a delayed, but it can completely change the trajectory of the management of that particular patient. And the multidisciplinary care, especially close communication with your radiologist, your laboratory, what we are doing, why we are doing, which machine we are doing is very, very important, equally important the medications which we are giving. And with the end, I will acknowledge our management. This patient was very challenged financially, so our management has gone out of the way to help these patients. In fact, I have to tell you that patient was admitted in the night, and within 36 hours, she was in CTVS OT and subjected to surgery. So this kind of prompt and immediate actions we generally see very few times only. So, and with this, and then other departments, urology, CTVS, neurology, radiology, oncopathology, anesthesia, everyone I am highly grateful on the behalf of Department of Endocrinology, CCR review committee for their insightful comment and critical analysis, and last but not the least, the patient and family who actually showed so much continuous faith and in us that they gave us. So there were a lot of financial issues. So as soon as we advised,
mother bhi bahar gayi.
As soon as we, so the son was as soon as we advised that it's a CT, MRI, IPSS, so they panicked. So they went to. For mother, because they stayed in the city, so the another hospital is much more closer, and it was happening in the night, so they first took her to the hospital, but within 3 hours they bring her to this hospital. So that's it.